Thank you, Lado, and a warm thank you to the organizers. I never heard the term black and white mono, but I enjoyed it. It's very nice. It's a great course. It's an honor to be part of it, and it's probably one of the absolutely best courses run in Europe because it has a large faculty, it covers all theoretical aspects of the shoulder, and it also has a cadaver part. So, if we look back to the history of shoulder dislocations in the pre-radiographic area, the pathomechanism was based on cadaver studies and autopsy findings, and the first publications on treatment of shoulder dislocations came in the 18th century by Pertus, who introduced a soft tissue approach, later copied by Bankart in the English-spoken areas, and Eden was the first to publish a bony procedure. That was also published by Ibinet. They were doing this independently. They didn't have internet at that time, so things developed on different parts of the world independently. Eden was first using tibial grafts, but finally both authors recommended the use of iliac crest grafts for the procedure. Later modifications by Lange and also Lavik was a Scandinavian, and in Norway this procedure was named after Alvik, a professor at the Oslo University Hospital that has his own slight modified technique, and this picture you see here is from his drawings to present this procedure, which became very popular in Norway in the 70s and 80s. Later, we have had arthroscopic techniques introduced by Taverna that's focused on the bone loss. The history about Latarjet and Bristow, we know it was first published by Latarjet from Lyon, and Bristow was published by Helfet in 1958, South Africa, and named after his former chairman. Arthroscopic Latarjet was first published by Lafosse and then Bouralot. Both have revised their procedures on several occasions, and they and others have reported numerous complications, even very serious complications like axillary nerve transection has been reported. So for many, many, many years, treatment was based on tradition and not the actual pathology. But then, in Arthroscopy 2000 came this game changer by Burkhardt and De Beer, where they showed that Bankart procedure performed in patients with bone loss had really high recurrence rates. So they introduced then the modified Latarjet procedure to solve this bony problem. And that publication was confirmed 7 years later in also the same journal. Conclusion then was that you can expect good results with the Latarjet procedure in this challenging patient population. Several bone block techniques have been published over the years. I will not go into detail. They have their advantages and their disadvantages, and you have to learn how to do them if you want to do them. The current indications for bone replacing procedures is in primary, first-time surgery, I call that primary, significant bone loss, high numbers of dislocations, young age, male, contact sports, hyperlaxity, and the absence of sufficient soft tissue. In reoperations, it's the most recommended procedure to use a bone block procedure. This is a treatment algorithm that published in 2015, that focus on the risk factors. We all know them. I will not go into details. They've already been mentioned by many speakers. So the discussion now is more what is the result, what is the importance of combined bone loss, and what is the critical amount of bone loss both sides. Unfortunately, we don't have the exact answer to these questions today. This publication focused on bone loss in first-time dislocators, and it showed that up to 22% of first-time dislocators had some glenoid defects, and up to 70% had humeral head impression. And in recurrent dislocation, the figures increased to 49 to 86% of glenoid defects and up to 100% of humeral head impression. So you see, it's very, very frequent thing to have a bone loss, more or less. They did not give any recommendation about when the bony procedure would be indicated in this paper. So the biomechanics is not completely understood, but it's become apparent that even minor bone loss down to maybe 10% or 13% can be associated with failure. And bipolar bone loss is important to recognize. This is one of many treatment algorithms, and we can look more into that in detail afterwards. Treatment of bone loss. Many different procedures have been described and published, and in general, they all work if they're done properly. Problem with bony procedures is that they have a lot more complications than the soft tissue procedures, 15 to 30%. Published in this systematic review. And they are both intraoperative and postoperative complications, as you can see from this slide. So then you have the soft tissue procedures. The Bankart is today the most popular one. We have skipped the Petit Plat and the Magnussen Stark. Are no longer used, I think. So it's the Bankart done open or arthroscopically. We can have remplissage, we have capsular shift operations, open or arthroscopically. We have ASA and DSA. We have combinations of the above mentioned. So what's in the literature when we look at this? This study reported on arthroscopic Bankart repair associated with subscapulary segmentation, the ASA, and compared it to open Latarjet, and they found that arthroscopic subscapulary segmentation of Bankart is an effective procedure for the treatment of recurrent anterior shoulder instability with glenoid bone loss without any significant difference in comparison with the well-known open Latarjet procedure. This paper, chronic anterior shoulder instability with significant Hill-Sachs lesion, arthroscopic Bankart with remplissage versus open Latarjet. They also found in these patients who had a significant Hill-Sachs lesion and a glenoid defect less than 30%. It was a retrospective cohort study, so it was not designed as a comparative study to start out. The follow-up was 4 years, and they found no difference in recurrence rate in this study. This study comments on recurrence and return to sport after surgery for shoulder instability, arthroscopic Bankart versus Latarjet procedure. That's also a retrospective cohort study. Some scientific flaws in the study. It's only questionnaire and phone, no clinical examination, and the follow-up was only 61% at 2 years. So the results has to be looked in that perspective. They found a much higher recurrence rate with Bankart, 18, compared to 3% with Latarjet, and a higher return to training and to competitive sport with the Latarjet than with the Bankart. This study compares arthroscopic Bankart versus open Latarjet as a primary operative treatment for traumatic anterior inferior instability in young males, a randomized controlled trial with 2-year follow-up. This is actually a very strange study. It was a multi-center planned randomized controlled trial between several Finnish university hospitals. Was sent to Kesta for publication, but never occurred there, but I found it later in this Journal of Sports Medicine. They found a redislocation rate of 21% at 2 years with Bankart and 2% with Latarjet, but with all secondary outcome measurements without significant difference. The strange thing with this study is the inclusion criteria, because 1/3 of the patients in both groups had significant bone loss, more than 20%. So why would you compare Latarjet with a procedure that is never been indicated for these patients? It's very strange. So it actually only confirms the publications by Burkhardt from 2000 that if you have significant bone loss, you should not use a Bankart procedure alone. This study, Bankart repair versus Latarjet procedure for recurrent a systematic review of 3,300 shoulders nearly. They conclude that the results show that the Latarjet had less risk for recurrence and redislocation with longer follow-up time, and both procedures were comparable in terms of ROE score, the need for revision, and postoperative hematoma formation, whereas Bankart repair was associated with lower risk of infection. This looked at the cost effectiveness of arthroscopic Bankart versus open Latarjet, concludes that both procedures are very cost effective. However, the Bankart is more cost effective because a failed Latarjet has a much lower health utility status than a failed Bankart. So therefore they conclude that the cost effectiveness of Bankart is higher than the cost effectiveness of the Latarjet. This systematic review compared Latarjet, Bristow, and the Eden-Hübinette procedures and looked at more than 3,000 shoulders, level 2, 3, and 4 only, and they evaluated the clinical outcome and recurrence. And they find that both procedures are effective. The Eden-Hübinette procedure has clinical outcomes very similar to Bristow-Latarjet technique, but has a higher rate of postoperative osteoarthritis and recurrence. And they recommended the arthroscopic Latarjet procedure as to be promising. So this study looked at the bony reconstruction of the anterior glenoid rim, 12 level 1 studies, 3 level 2 studies, with a good assessment of bony deficiency with CT scan, looked at biomechanics and the results. And the conclusion is that biomechanically, the Bristow-Latarjet have the greatest stabilizing potential due to the sling effect. But there is promising results with arthroscopic Latarjet. Bone block procedures have shown good results, nice remodeling, with also implant-free techniques. So, to summarize, bone block procedures are indicated with glenoid bone loss. The amount of bone loss has still to be decided. There is a reported increased incidence of osteoarthritis with all bone block procedures, even in relatively short follow-up studies. They're possibly related to both technical errors and articular damage from repeated dislocations. So what's the take-home message? Coracoid and iliac crest bone grafts works well for glenoid bone defects, and glenoid defects are usually located at the 2 to 6 o'clock position. Graft positioning is probably important. Prone position increases the risk of osteoarthritis. Too high increases risk of injury to suprascapular nerve. And too medial is less effective. In combined hyperlaxity and structural injury is probably a good indication for Latarjet, which adds the sling effect and increases dynamic stability. It's something to think about that bony augmentation procedures increased tenfold in the US from 2004 to 2013, but the complication rate was unchanged, 20%. Some issues where the jury is still out. What to do about combined defects? Should we add remplissage? Should we do bipolar grafting? What to do with graft breakage, healing of the graft, resorption of the graft? Has this to do with mode of fixation, harvesting techniques, donor site morbidity? What about combined soft tissue procedures, capsular repair, closure, tensioning for the inferior glenohumeral ligament? What about complication rates that's for the bony procedures remain high? And what about the persistent disability seen with inferior instability, which is something very hard to treat? And finally, what about the development of osteoarthritis? In conclusion, there's no single procedure that can be called the golden standard. Some cases benefit from combinations of different procedures, and you should be aware of the risk factors, expectations of the patients, and the clinical presentation, and you should tailor your treatment individually in every shoulder instability case. So the answer to the question asked, is Latarjet the golden standard? The answer is no. Thank you.